Welcome to the doctor's office. I'm Dr. Earl Hill, and today we're going to talk about substance abuse. And joining me in the doctor's office is my good friend Ed Lyons from Peterkins Associate right here in Fayetteville. Welcome, Ed.
Thank you for the opportunity to come here, Doctor.
My pleasure, my pleasure. Tell us about substance abuse in the United States, and since it's a pandemic, you can even include the world.
Well, substance abuse, of course, has been going on for thousands of years, and it usually becomes more prevalent after wars and times of stress.
You think it's because of the stress?
The actual cause of substance abuse is usually a reward deficiency. When a person is born or genetically predisposed or starts experimenting with drugs, and the mind gets hijacked, as they say. And when you start dealing with drugs, the reward system in your body changes, and your body thinks that those rewards are coming from things that you do naturally, such as sleeping and eating. And when it gets mixed up, then the body thinks it's a matter of life or death for you to get the drugs.
Is there some recreation involved in that process beyond the psychological effect of that?
The funny part of that is that the reward deficiency is usually onset in adolescence. So an adolescent looks for rewards and different things that makes them feel good a little bit easier, and that's why that's why they're bored so much. So when they start abusing drugs or start experimenting with drugs in order to find those rewards that they don't naturally get, then the dependency sets on, as opposed to the abuse.
You think it borderlines on the pleasure principle and pain avoiding? You think that's some of the innate causes?
Absolutely. And I think it's a lot simpler than we could make it real complicated in talking about the synaptic centers and the medulla. But the fact of the matter is when we start putting chemicals in our body that give us rewards, the body can't distinguish those rewards from the natural rewards that we instinctually look for in order to survive as a person and as a species.
I guess we need a little pleasure in our lives, but not that kind.
That's true.
Now, do we have numbers associated with substance abuse, and how broad is the range? What are we talking about? What are some of the substances, and what constitutes abuse?
Abuse comes with a manipulative use. It doesn't become actual dependence, according to the DSM-4, until it meets criteria that includes tolerance and withdrawal and psychological dependence, such as driving long distances in order to achieve the drug, or using more than you originally intended, giving up social or occupational occasions in order to use, being told that you should quit by a physician and continuing after that, even though the consequences are going to be dire and you know it. Those are dependencies, diagnoses. But it's a wide range. The things that we're seeing now is the crack cocaine and the amphetamine addictions, and methamphetamine that's coming this way. North Carolina is getting ready by putting certain treatment modalities in place, trying to gear up for methamphetamine. But crack cocaine is so prevalent and so addicting because it's smoked, of course, and it goes straight for those pleasure sensors, those rewards in the brain, and a person becomes addicted real quick to it.
Is there age disparity? Who's smoking this crack cocaine and this other stuff?
Generally, when I look at the ages of people who are seeking treatment, it's between 28 and 35, but as a spike. But I have many clients that are up in their 50s and 60s.
Man, they live that long? God.
And some that don't start smoking crack cocaine until later in life, after they've been using alcohol for years and years and switched drugs.
Is there a gender disparity? Is it more women smoke or more men smoke?
I see that. I come from treating criminal justice involved clients, so most of them are males. I see more males that come into our facility down here in Fayetteville than I do females. However, a female, when we're talking about alcohol, they become dependent on alcohol faster. They get sicker, and they stay sicker longer because of our society. We support them even during their addiction, so they stay sicker longer. And some of that has to do with the lack of some of the chemicals, gastric dehydrogenase in their stomach, not being able to digest it as fast as males can, who can metabolize the alcohol a lot faster. But when a woman starts drinking, and heavily, she usually becomes addicted a lot faster. Yeah.
What about racial disparity? Is there more one race smoking and dipping and getting arrested and in jail than others?
And I don't know that it's much of a disparity about the disease or the conviction rate, or many people have said that they have focused on one drug as opposed to the other because of a racial difference in who's using them. But we have a lot in Cumberland County of substance abuse. 66 people out of 1,000, according to the last report, were in need of substance abuse treatment. Peterkin has a substance abuse intensive outpatient treatment program on Hay Street. Now, when you start talking about substance abuse treatment, a lot of people get confused because there's different kinds. There's a primary treatment. Primary prevention is when that's when you have posters in schools. You have people dressed up like dogs that go out to the high schools and tell people not to smoke or not to use drugs. That's primary. Secondary prevention is those things that you see on commercials when they say drink responsibly. They know you're going to be drinking anyway, but they want you to do it so that you don't get hurt. It doesn't become a big problem. Tertiary prevention is what we deal in. This is after you've already started using, it's already become a problem, and it needs to be addressed. Now, the different levels of tertiary prevention is outpatient treatment, when you come and see someone once a month and you have some kind of education behind it, and then it progresses and levels up with a continuum of care all the way up into hospitalization. Intensive outpatient treatment is when you need more support than just once a month or even once a week. It's 3 times a week, 3 hours a day, and includes education in the form of films and lectures, group therapy, individual therapy, and activities such as going out in the community and go to AA and NA meetings. It is as close as you can get to comprehensive treatment, which would be five days a week and 5 hours a day, or even more. But we offer that in Cumberland County on Hay Street, and the program's growing because of the mental health reform in North Carolina. Many of the mental health centers have divested services, and we have a lot of very, very talented substance abuse counselors here in Cumberland County. So we're very fortunate to be able to take up the treatment demands that this county needs.
So mental health is just a referral agency now?
Mental health has become a referral agency that monitors providers, One of the things that Peterkin stands by, and one of its values, is that we're going to be accountable and effective. We're not only monitored by them, of course we're self-monitored and we have our own values, and we are dedicated to providing a level of services that we are going to have outcomes measures, which we have, and performance improvement activities that make sure that we have modalities that are cost-effective and have results. The taxpayers in North Carolina pay for results, and we agree that we should be helping that consumer get out of the pain they're in, raise the level of the quality of life that they're living in, and to reduce the reliance on other sources of support, and keep them from going into crisis, and lower the crisis rate. That once mental health, of course, is divested, and we have a reliance on the ER a lot of times, that's the only place that they know where to go to find help. So we're providing an array of services here in Cumberland County in order to relieve that and serve the consumer.
Well, it sounds like y'all are really doing a good job with prevention, support, and treatment. Right. Do you find which drug do you find that patients are using, or clients are using the most of?
We, in intensive outpatient, we see the most of crack cocaine use. However, there is several treatment centers here in Cumberland County that treat opioid clients, so we see some of those as well. Taking pain medication or using heroin.
I didn't want to leave that part out about the group that gets arrested the most and go to jail. What group was that? We had talked earlier about the group that seems to go, and the crack cocaine seem to be the one that is punished the most. And what is the reason for that? Is there a racial disparity?
And for years they have said that the difference in the type of drug that African Americans have used, or what they have perceived that they have been using, the crackdown on that has been a racial one. Back with marijuana in the 20s and 30s, all the way up to crack cocaine now, the difference in the punishment between powder cocaine and crack cocaine, of course.
Yeah. I just wanted to mention that disparity. What about for medicinal purposes? Do you subscribe to that?
I think that the medical and the mental health field have medicines that help people. I don't think that any psychoactive medication should be self-administered. We're always looking at the possibility of dependence. And I believe it's like a diabetes. The first time that you go into a diabetic shock, you did that because of ignorance. But if you don't take care of your diabetes, you go back into the shock. So once a person learns that they're dependent, they have to seek treatment. They need to seek treatment, or else, of course, they're going to go down that road that leads one to the lifestyle that we see.
What is there association from drug use to AIDS? Is there some kind of bridge to that? Is that separate and apart from what we're talking about, substance abuse?
Well, of course, anytime we use an intoxicant, our reasoning goes out the door. So we make choices that we normally wouldn't do, take risks that we normally wouldn't take, and associate with people that we probably wouldn't associate with. So as soon as our decision-making process goes out the window, we're actually leaving ourselves vulnerable for a lot of things.
So that AIDS seems to be another pandemic problem.
Actually, our organization has a section that addresses that. HIV-affected clients and their loved ones and families, to where we address the substance abuse that seems to be prominent in the HIV-infected population.
Which is there age group that's more prone to, or is there an age group that's rising than the others that's more prone to be affected by AIDS than others?
I understand that heterosexual females is the population that's growing as being the ones that are positive for HIV.
Mm. Is there any scholarship on why that's happening?
I believe if we look at, and I'm not the expert in HIV, but if we look at it worldwide, the profile for it is heterosexual. And so the growth in other countries, it being a heterosexual disease there, as it evens out across the world, it would become a prominent heterosexual disease here as well.
And that's a big switch from what we originally thought. It just was designed for or caused by homosexuals. So we've gotten rid of that myth. So, you think the heterosexual males are bringing it home? How do they get it? Or the females are engaging in needles and sort of things that cause them to be subjected to it?
I could speak to the substance abuse and substance treatment portion of that the substance abuse counselors mandatorily have to attend training each year or every other year in order to stay up on HIV, because it's so prevalent with substance abusers and substance dependent people. And so whether it's coming from promiscuity or needles or other risky behavior, it certainly is affecting the world in general.
What about the children? How's it affecting the children? Because we have now that children are born with, it's called crack babies, and they're coming to school, and from what I can gather, they're hard to teach. Because I have a clinic, and we find a lot of those kids coming with some disorders that we hadn't heard of years ago.
And we're seeing more and more we have to treat the whole family. Substance dependence is a family disease, and the children are affected, extremely affected by this, and sometimes for the rest of their life. And many of my clients will remember and reflect that Daddy was an alcoholic, and Mama was an alcoholic, and believe that some of the causes of their addiction actually go back on how they were abused as a child because of the substance abuse in the home. So when we bring in a client, and consumer, we usually advocate that they bring their family in, their spouse, and let us talk to the children and see if we can't work out that part of their life and get counseling for the whole family.
And break that cycle, because there's a chance that they might see those as models and end up doing it themselves.
Absolutely. The intensive outpatient program is comprehensive in that it looks at each area of the consumer's life, the vocational, the family, the coexisting mental health conditions that might be in their education, and when we look at any problems in there, when we find those problems, we discuss it with the client, and we build a personal plan for them designed just to address those issues that come up during those assessments. One thing Peterkin stresses as one of its values is consumer choice. So when we build a treatment plan, it's based on the preferences, the strengths and the weaknesses of that particular client. It's the plan is agreed upon between the consumer and the counselor, so that the consumer buys in to the changes and actually helps design the plan that will initiate those changes in their life in order to improve the quality of life.
So it's like the life-space interview technique where they have an alternative, but they have to carry out the alternative?
Absolutely.
Okay.
Some of this is, some people have said addiction is a disease. Some of them say it's a moral issue, values issue, and some people say it's a cognitive behavioral problem. And I say it's all. Just like diabetes that I alluded to earlier, that's a disease. But it's also a cognitive behavioral problem that has to be handled with the right choices. Right. And so after the disease is kicked in and they understand that they have addiction and they have chemical dependence, they have to make the right choices in order to seek help, in order to gain a support system around them, put themselves in the right situation, in the right environment, and do the right thing in order to manage that disease.
By cognitive behavior, you mean you have to think about it and internalize it yourself mentally, and then to change your behavior? Is that what you mean by cognitive behavior?
Absolutely. And of course, then we come down to the moral issue. People think it being a moral issue. And the little-known thing about substance abuse counseling in the Minnesota model that we use, we're bringing these people back into Alcoholics and Narcotics Anonymous, which in turn brings them back on a spiritual path that returns them to their religion of origin. So in the long run, it's a pathway back to their higher power.
Do you think there's is there a cure to it? Do you have a cure rate, or is there really a cure to this substance abuse?
Well,
pandemic.
The substance dependence is a diagnosis that will last the rest of your life. And some people try to ask what is the success rate of a substance abuse program or a substance dependence program, treatment program. And I always say what we're doing is we're offering those choices, those cognitive behavioral choices, and gaining insight to the disease in order for that person to live a better life. They may not continue to be abstinent for the rest of their life, but it may reduce that use. And each time that they have a relapse, they know where to go and what to do. And so I say that we are successful in that. Historically, the amount of people that actually complete treatment programs is about 80%. And that may be the first time or the second time or the third time that they go through the treatment program. But that seems to be the optimum number. We could probably complete them all, but would we be effective?
The moral part, I've been reading lately, they said that's the only sure way is to have some kind of divine intervention. That, you know, the treatment and going through the cycle and all of that is one thing, but you need all the help you can get with this kind of abuse and with these kind of addictions. And so you go through it, and the people that I've talked to that have gotten off of it said they needed all the help and they had to pray a lot. So I'm not, you know, that's what that testimony was, but they said that's otherwise you just can't count on people, you know, kicking it for good. That you need to, you know, like pray daily. And I guess those 12 steps. You have to go on a daily basis.
Yes, sir.
So that shows the magnitude of this substance abuse. Now back to prevention. What you think that's the way to go? You think we to make sure we try to prevent groups of people from not getting on it, the ones that are more likely to become addicts? We need to talk to them more, do more than talk, take them out of environments that will subject them to that. What do you think?
Well, and as I said before, prevention is the designation for what we do. Whether we're keeping them from starting, we're keeping them from progressing and it becoming a problem, or us not preventing them from going back and using and causing more damage. So we're in the prevention game all the way through. The most money that's spent is in primary prevention. That's the ads that you see on TV and trying to keep the kids from starting in the first place, or using responsibly later on. The least amount of money is actually spent in treatment, in tertiary treatment. We have far too little treatment in North Carolina right now for substance dependence and substance abuse treatment.
How does cigarettes, smoking, tobacco, and all that play in there? I
believe nicotine is probably one of the most addicting, if not the most addicting substances that is abused today. And we'll see more treatment centers for nicotine and more ways to quit smoking later on, I'm sure. It's becoming less socially acceptable. But I would far rather work in a heroin detox than a nicotine detox center. It seems like that addiction goes on for years and years, and I quit smoking in '99. I know one thing, is that I can't have a cigarette. Mm-hmm. And though I look at them and I smell them, I can't have one cigarette. They have something that was called, coined years ago as spontaneous recovery. Mm-hmm. I used to think that was something good, because recovery is always a buzzword for addicted people and wanting to recover. But as I read into spontaneous recovery, actually what it is we have a habit and addiction. And once we go back, even though we have years and years of recovery, the thing that we recover in spontaneous recovery is we recover that habit just as soon as we use one more time. Mm-hmm. So it's like Pavlov's dogs and ringing the bell and them salivating. Even after years, we one time that we ring the bell and we feed them, mm-hmm. The habit's back on again. And that's one of the reasons why we advocate abstinence. Mm-hmm.
Well, if people need your service, how are they able to get in touch with you?
Well, we're at 131 Hay Street, mm-hmm. at 483-0335.
Okay. What role does Sheila play in all of this? Sheila McLaughlin.
Sheila McLaughlin is a part of our committee that takes care of our policies and procedures, and she's also our public relations component. And she does a real good job for us. Our compliance committee is where she works. As I said before, that we have policies and procedures and committees we self-regulate, and she's part of that.
Well, you give her my regards and thank her for putting us together, and they could always ask for Sheila if they can't think of another name.
Absolutely.
Well, and also give my friends down at Peterkins Associates my regards and tell them to keep up the good work. And we're certainly glad to have you come on in.
Thank you. Thank you for the opportunity.
It's my pleasure to have to come back again and bring us up to date.
Will do.
This has been Dr. Earl Hill in the doctor's office, and joining me in the doctor's office has been Mr. Ed Lyons of Peterkins Associates right here in Fayetteville. We hope you watch the show, and we'll see you next time. Take care. Yeah, it's really, you did a great amount of service for us.